slightly and the curve has been flattened slightly, it still is very, very significant and has not changed much with time. Now, I am going to address today a couple of issues: pain, acute chest syndrome, and multiple therapeutic modalities: hydroxyurea, transfusions, glutamine, and new therapies. And you have to realize that pain or vaso-occlusive crisis is a hallmark of sickle cell disease. This was described by Dr. Ballas, who is originally from Lebanon, working in the US. You have a prodromal phase, an initiation phase, an established phase, and the resolution phase. And this pain crisis takes usually about a week from start to resolution. So one has to be cognizant of that and to treat accordingly and not expect or hope that the pain will go away anytime sooner. Now, many patients experience continuous chronic pain with breakthrough and exacerbations on top of that. Now, a couple of important findings. Patients with sickle cell disease are mismanaged or managed poorly everywhere in the world, in the developed world, in the developing world, because of certain stigma. They have longer waiting times in the emergency room, and we really need to address this. And we know that where guidelines for treatment are available, the management of vaso-occlusive crisis is better and faster. So development of guidelines for treatment in different institutions is important. And the barriers to effective pain management could be multiple. There are socio-cultural factors, but very important is the concern that we have that these patients are addicted to pain medicine, even though the rate of addiction to pain medicine among patients with sickle cell disease is low. An important complication of sickle cell disease is the acute chest syndrome. And this is defined as a new pulmonary infiltrate involving at least one complete lung segment with chest pain, fever, tachypnea, and hypoxemia. And it complicates 30% of admissions for painful crisis, and it's also the most common post-operative complication in these patients. The causes can be multifactorial: infections, bone marrow emboli, thromboembolism, and atelectasis due to pain and splinting of the chest. Now, when we study these patients very closely, we can establish a cause in about a third of cases, and they fall along what I mentioned: infection, infarction of pulmonary embolism. As I mentioned, the acute chest syndrome occurs in 30% of patients hospitalized for pain, and incentive spirometry is important. How do we manage this? Transfusions are key to improve oxygenation and anemia, and especially if there is progression by chest X-ray. Now, exchange transfusion is reserved for severe patients who have a poor response to oxygen. We need to manage their pain and give oxygen. And I have to mention here that that antibiotics are key. Sorry, I skipped this: hydration, but not overhydration. Antibiotics, third generation antibiotics, and then macrolide to cover atypical bacteria. And one needs to consider bronchodilators, as asthma is a very common in sickle cell patients and complicates this disease. Now, acute chest syndrome is often an iatrogenic condition. This is a study from the US where, before they had a good protocol for pain management, 25% of patients admitted for pain had acute chest syndrome. When they had standardized order, caregiver education, incentive spirometry, they could decrease this to 12%, and the time to develop acute chest in the hospital for patients admitted with pain improved. So good management of pain and guidelines and physician education are critically important. How can we prevent acute chest? Hydroxyurea is very important, and patients who are on hydroxyurea have fewer episodes. Patients who are on chronic transfusions also have many fewer episodes, and this we found as a secondary endpoint in the STOP study. Patients who were transfused for stroke prevention had many fewer patients, had many fewer episodes, 4.8 per 100 patient years compared to 15 for patients who were in the non-transfused arm. Now, patients who undergo stem cell transplant for sickle cell disease have fewer episodes of acute chest syndrome. And as I mentioned, when patients are admitted for pain, if they have a good protocol of multimodal pain information with caregiver education, the acute chest rates decreased by more than half. And again, having incentive spirometry is very important. Recent findings, and this was published about 4 years ago, is that patients who present to the hospital and develop acute chest syndrome, they have a higher rate of acute kidney injury. And patients who received transfusions or did not receive transfusion still had acute kidney injury. So about 8% of them, but it's something that is important for us to look at. Okay, now what are the treatment options these days? The most important that led to improved survival are preventive measures: newborn screening, penicillin prophylaxis, vaccinations, TCD monitoring for stroke, screening for pulmonary hypertension, assessment for end organ dysfunction, and education of patients and families. But I will be talking about hydroxyurea, a little bit about transfusions, glutamine, and novel therapeutic options. Now, hydroxyurea is a simple compound that has been around for a long time, that has a multitude of effects on sickle cell disease, increasing fetal hemoglobin, decreasing white cells, decreasing adhesion, and it's also a nitric oxide donor. Now, as I mentioned, it increases fetal hemoglobin, and in a randomized study, decreased the rate of pain crisis and acute chest syndrome by 50%, which led this to be the first drug to be approved in the United States and later in Europe for the treatment of sickle cell disease. You can see here in a study from Belgium that patients treated with hydroxyurea had a markedly improved survival versus patients who received no treatment or hematopoietic stem cell transplants, and only transfusions came close. This is a study from Brazil in children showing improved survival of children who received hydroxyurea compared to children who did not. And the survival was 99% compared to 94%. Similar studies from all over the world show a survival advantage for patients who receive hydroxyurea. On the other hand, toxicities from the drug are not much. Leg ulcers are similar in patients on hydroxyurea. The fear of leukemia did not happen, okay, or other cancers. Now, there might be a decrease in spermatogenesis, but this still needs to be further studied. And there doesn't seem to be a lot of adverse impact on pregnancy or pregnancy outcome. We still ask women not to get pregnant on hydroxyurea, but the data is not there. We can see here that there is a decrease in total sperm count on patients after 6 months on hydroxyurea, but the impact of this on fertility has not been well studied and needs to be further defined. Now, at what age do we start it? This on the left-hand side is the results on the baby hug study, where hydroxyurea was started in babies 6 months of age 9 months of age or older. And you can see that compared to the study in adults, it's very similar. Decrease in pain, decrease in acute chest, decrease in dactylitis, of course, which is only seen in children, decrease in hospitalizations, and significant decrease in transfusion. So now the recommendation is to start children 9 months of age or older on hydroxyurea, regardless of severity. That's not always easy to convince the parents, but we really need to do our best to use this drug. The drug, there were many questions about its utilization in various parts of the world, and this was presented in ASH last year, the REACH trial where hydroxyurea was utilized in sub-Saharan Africa. And even in that setting, the adverse events amongst hydroxyurea patients were significantly lower in the sub-Saharan African setting, no matter what episode you looked for. Sickle cell related events, malaria was even better, fewer transfusions, fewer vaso-occlusive crisis, fewer acute chest syndrome, and decreased mortality. So hydroxyurea was safe and effective in many settings. Now, recent advances, people are looking, and our colleague, Professor Ware, is looking at the pharmacokinetics of hydroxyurea to see if we can determine the optimal dose for a patient based on pharmacokinetic studies from the get-go. Now, an important question, this was also presented at ASH last year, the manuscript is to come out, the hydroxyurea and breastfeeding. And 16 women, 14 healthy volunteers, and 2 sickle cell took hydroxyurea, and they had the levels mentioned measured in breast milk. The breast milk concentration was 80% of the plasma concentration. Most of it was excreted in the urine, but the exposure of infants to hydroxyurea from breast milk was really minuscule, and over 24 hours after a dose, and could be reduced to a very, very small amount by pumping the breast milk after 3 hours. And so it is important to note that whereas in the past this was recommended for mothers to stop breastfeeding, that now we will be recommending that they pump out the first milk after having taken the dose and continue breastfeeding. What about transfusions? Transfusions are very effective in sickle cell. They can be used to prevent acute chest, stroke. They can be used for severe anemia, aplastic crisis, sequestration crisis, but there are risks: alloimmunization, delayed hemolytic reactions, and this is why we need to tight patients up front and monitor them closely, and iron overload in the chronic setting. Most importantly, we did not know how transfusions work. And this is work that's just coming out to look at the impact of transfusions and exchange transfusions on the brain. And you can see that exchange transfusions decrease cerebral blood flow and the oxygen extraction fraction without decreasing brain metabolism. And decreasing cerebral blood flow has salutary effects on the brain. And if you look at this article by Kristen and colleagues, you can see here that this is the brain in a non-transfused patients. This is cerebral blood flow. This is in a chronically transfused patient, and you can see that the cerebral blood flow is better. And this is immediately post-transfusion. And you can see here that the cerebral blood flow has almost completely normalized. The same applies to oxygen extraction fraction. So now we are learning more and more how transfusions work. What about new therapies? And I'll talk briefly about selectin inhibitors, glutamine, changing oxygen affinity, and quickly about gene therapy. Now, glutamine is a non-essential amino acid. It can be used for the management of burns. In sickle cell disease, it has been shown to improve, to increase NAD and improve redox potential, decrease endothelial adhesion, and decrease resting energy expenditure. There was a randomized trial of L-glutamine, and this is pharmacologic-grade glutamine in patients with SS and S-beta 0, more than 5 years old, and they got 0.3 grams per kilo BID. That's a significant amount of hydroxyurea for a 48-week period. And you can see here that there was a decrease in pain crisis and longer time to a pain crisis compared to placebo. And when they looked at L-glutamine versus placebo, time to onset of pain crisis was longer with L-glutamine, acute chest syndrome episodes were fewer, hospitalizations were less, and blood transfusions were decreased. Now, this was published in the New England Journal. There's still some questions about it. The drug, as it is being marketed, is very expensive, but in patients on hydroxyurea who still experience pain, it might be worthwhile adding L-glutamine. Now, remember what I mentioned to you about the pathophysiology, about it not being a simple plumbing problem, that adhesion depends on adhesion molecules. And selectins are important adhesion molecules. They really are associated with neutrophil rolling, but they play an important role in vasoocclusion by binding red cells to neutrophils, to platelets, to the endothelium that leads to hypoxia and tissue injury. And it stands to reason that if you can counteract the impact on selectin, P-selectin or E-selectin or pan-selectin, that you might impact vasoocclusion. I have to mention that all attempts to treat vasoocclusion with P-selectin inhibitors or pan-selectin inhibitors failed. So there was a product from Pfizer that was a pan-selectin inhibitor to look at treating pain crisis or shortening the duration of pain, and it failed. But if given on a prophylactic measure, it's okay. And it seems to work. Crizanlizumab is a new molecule that targets P-selectin that binds the adhesion of platelets and red cells to the endothelium. It's a humanized IgG2 that inhibits P-selectin binding. And this was the one from Pfizer that I showed you did not work, so we're going to talk about crizanlizumab. And in a study where there was a higher dose, 5 milligrams per kilo versus 2.5 versus placebo, randomized study, it was shown that the higher dose, the probability of a painful event was significantly decreased compared to the 2.5 milligrams per kilo or placebo. There was a significant decrease, almost half decrease, just like hydroxyurea, on annual rate of pain crisis. Some of the toxicities or adverse events were arthralgias, diarrhea, vomiting, chest pain, and pruritus. But we are using this drug now on a clinical trial setting, and we have really not seen much of these, but we have to be on the lookout for them, but quite effective. And the time to a first or a second episode was also significantly increased with the 5 milligram per kilo dose and 45% lower rate of pain crisis. And the adverse events occurred that occurred in more than 10% of the patients were what I talked to you about. Now, a different approach is utilizing a drug that binds to the alpha chain and will increase the oxygen affinity of hemoglobin. And this will lead to a decrease in the sickling mechanism. And this drug exists called voxelotor, and we have been using it. But the aim was to see if we could get an increase in hemoglobin of 1 gram per deciliter at 24 weeks. And you can see from this waterfall plot that in more than half of the patients, there was in 60% actually, there was a significant increase of hemoglobin of more than 1 gram per deciliter after 24 weeks on this drug compared. This is 1500 milligrams, but there was response even with 900 compared to placebo. And you can see that some patients, many fewer in the 1500 milligram arm than placebo, had a slight decrease in hemoglobin, but the vast majority of patients had an improvement in their hemoglobin count. There was a significant increase in hemoglobin, as you can see here, and this was persistent over time. And there was a decrease in markers of hemolysis in these patients, decrease in indirect bilirubin, reticulocytes, and LDH. So as a conclusion of this study, and I did not show the old data, there was an increase in hemoglobin that was sustained for 24 weeks, generally safe and well tolerated. And this is an oral drug, by the way, compared to crizanlizumab, which is an IV drug given every 3 weeks. This is given daily. Numerically, there were few vaso-occlusive crises, and we're still monitoring this to see if it will reach statistical significance. And there was no increase in hemoglobin levels, and there was a reduction in markers of hemolysis. Now I'm going to come to gene therapy, which seems to be the holy grail in sickle cell disease. Why gene therapy in sickle cell disease? And I want to start by showing you that the only curative modality is stem cell transplants. In stem cell transplants, we take the blood stem cell, replace it, and we get normal red blood cells. Of course, the hematologists among you know that we need to treat the patients with chemotherapy and conditioning, collect bone marrow from a donor, and then give them back to the patients. And this is usually an allogeneic stem cell transplant. Okay, it's the only cure, and the results in many studies showed that transplant from matched related donors offer an approximately 85% chance of cure. It is a risky procedure, but the risks are small, and early studies are optimistic. And you can see here that it can prevent stroke, and we have been able to improve the results by adding ATG over the years. And the overall disease-free survival is now 95% using chemotherapy and ATG. Now we have looked to see if we need to use myeloablative regimens. And these are the results of survival and disease-free survival. And myeloablation is not always necessary. This was a study that has since been expanded in adults when non-myeloablative sibling-matched transplants were well tolerated, led to normalization of hemoglobin, and most patients experienced the mixed chimerism, and they did well. But why not do a bone marrow transplant for everybody? Not everyone has a match. There is still a risk of graft versus host disease. You need immune suppression. There is a risk of late rejection. And of course, there is a risk of mortality with the procedure. Sickle cell disease is potentially amenable to gene therapy as it's caused by a single gene mutation. And we can deliver, if we can deliver a functional gene to the stem cells, we can also decrease the symptoms of the disease. And this will circumvent the need for a donor, as the patient can serve as their own donor and should have less immune-mediated side effects. So you'd harvest the patient's cells, treat them and fix them, and transplant them back after giving some chemotherapy. Now, what types of gene therapy are currently used? Gene addition, where we add a new gene. And here we are adding a hemoglobin molecule that is similar to fetal hemoglobin that interferes with sickling. Or we can do gene editing, where we can edit the genes and increase the percentage of fetal hemoglobin in cells. And these are the two techniques that are currently in use. This is gene addition using a viral vector, and this is gene editing where you use CRISPR-Cas9 in order to do that. Now, there are some terms that you would know. How do we measure gene therapy? We need to look at the vector copy number per cell, the percentage of stem cells that are transfused, and the amount of the patient's own blood cells that are returned to the patient after the gene therapy. And you can see here that this is a viral copy number of 1, where there is 100% transduction. Here, these cells have 2 copies, the others have none. Still, you have a viral copy number of 1 with 50% transduction. And you're going to hear more and more about these as these results are published. There has been once a patient published where the hemoglobin A T87Q was introduced into the cells, and this the hemoglobin concentration increased with time, and the patients were making a significant amount of this transduced hemoglobin with gene addition. Another patient has been treated, or more than one patient have been treated with this technique. Other patients have been treated with CRISPR-Cas9 technology to block BCL11A and increase fetal hemoglobin, and therefore improve the pathophysiology of the disease, and these are also ongoing. And you can see this, this is the result of gene addition studies, and you can see the different percentage of the, this is SS, and the red is the changed hemoglobin. Now, these studies are still very early. We need to still see, is this going to improve the disease outcome? Is this going to make people feel better? Is this going to impact end organ function? Is it going to decrease kidney failure, strokes, and other kinds of organ damage? So, not to run over time, sickle cell disease is associated with many potential complications, including some that I talked about. Preventive measures are really critical. There are viable treatment approaches such as hydroxyurea, transfusion therapy, and stem cell transplant, and other new interventions and new agents are actively investigated. Thank you very much. I'll end here. And again, I want to thank the organizers for having me in this wonderful meeting.
Dear Professor Abboud, I want to give a big thanks to you for joining us, for accepting our invitation, and also for sharing this awesome, wonderful slides and your awesome lecture. Thanks a lot. And also, I should give you a big excuse for waiting for about 15-20 minutes. We faced a technical problem with opening ceremony, which affect the whole B. But I'm so sorry for that, and thanks a lot for your tolerance. Next, we are going to. You're welcome. You're welcome. Thanks a lot, and thanks all. Next, we are going to be with Professor Flora Peyvandi from Università degli Studi di Milano and Luigi Villa Foundation, Milan, Italy. Professor Peyvandi, we are with you honorfully. Thanks a lot again to you for joining us, for accepting our invitation. We are going to have Dr. Peyvandi's lecture.
Good morning, I'm Flora Peyvandi, in charge of Hemophilia and Thrombosis Center of Milan and working at the University of Milan. And my work today would be to talk about what are the novel treatments in hemophilia. As you know, hemophilia is a rare inherited bleeding disorder which is caused by deficiency or dysfunction of the coagulation protein factor VIII for hemophilia A and factor IX for hemophilia B, and those factors have an essential role in the coagulation cascade. And the dysfunction of this protein cause a defect in clot formation, as you can see in this cartoon, with a consequent bleeding diathesis. The classification of hemophilia depends to the residual amount of clotting factor and its deficiency. For both hemophilia A and B, the severe cases are associated with less than 1%. The moderate is reserved factor of 1 to 5%, and for the milder one is about 5 to 40 international unit or percent. And of course, that is proportionally related to the number of bleeding events per year. And if a patient is not treated as prophylaxis, in the severe cases, the patient could have more than 20 to 50 bleeding episodes a year, which is spontaneous, and that is reduced by the increasing amount of the circulation factor. The spontaneous bleeding could happen at different joint level, and that might differ from children to adults, and the muscle and soft tissue, as you can see, also are involved, and there are also additional sites that could be involved with non-musculoskeletal like GI bleeding or CNS bleeding, which is still the highest number of mortality in the hemophilia patients. And again, as I said, the site could change from the children and adults, but ankle, knee, and elbow are the highest number of incidents in the patients with hemophilia. What's going to happen when we have a spontaneous hemorrhage in the joints and we have the target joint, which means the same joint that have recurrent bleeding? That leads to inflammation of the synovial tissue with synovitis and progressive damage, as you can see in this picture clearly, compared to a normal joint, with the progressive damage of the tissue and development of arthropathy, and that is associated with the limited mobility of the patient and reduced quality of life of the patient. And that's a picture that we are not anymore used to see in Europe, but unfortunately in the developing world still we can see the pictures like that and the clinical situation like that. So what has been changed in terms of the treatment strategy? As we know, the replacement therapy still by intravenous infusion is the main treatment in most countries around the world. And the treatment at the beginning was started with the on-demand infusion of the deficient factor VIII in case of hemophilia A and factor IX for hemophilia B. And then that has been improved by two strategies, home treatment and particularly prophylactic treatment. The regular infusion of the deficient clotting factor with a specific goal of preventing bleeding episodes and trying to improve the situation of the patient by a higher trough level in the patient about the level of the factor. And that is considered right now the standard of care in severe hemophilia. And what is the prophylactic regimen to achieve that type of goal is 25 to 40 international unit 2-3 times a week for hemophilia A, and for hemophilia B about 25 to 40 international unit twice a week. That strategy significantly improved the life of our patient. However, there is different points that still has not been improved and clarified. One is the limitation of the half-life of these factors. For factor VIII is about 8 to 12 hours and factor IX is a few hours longer. That means the infusion should be done, as I mentioned, for prophylaxis 2 to 3 times a week, and for the acute bleeding up to twice a day. And the immunogenicity of these factors. After HIV and HCV, the highest and the biggest complication of this treatment are the development of inhibitors in about 1/3 of kids in the first 50 exposure days. So these were the problem that needed to be solved, and how that has been at least improved are extended half-life products and other type of a strategy which is called non-replacement therapy, and finally gene therapy. Let's go to see where we are in terms of all the product. As I said, plasma-derived and recombinant, both they have short half-life with a frequent injection and inhibitor development in pups. And now how that tried to be solved by the novel extended half-life product. The two strategies of pegylation and fusion protein was used by chemical coupling of PEG, which increased the hydrodynamic volume of the factors, and by fusion of fragment crystallized region of immunoglobulin IgG1 or albumin to the recombinant protein. And both of this strategy tried to make what I'm trying to show in this cartoon. In the upper part of the slide, you can see a hemophilia patient with 3 injections a week, and in the lower part, a hemophilia B with 2 injections. And you can see when you use a longer acting product, you can improve the therapeutical approach by reduction of 1 shot a week and a little bit higher trough level. And about factor 9, the improvement is significantly higher, and you can reduce the number of injections by once every 10 days or every week, or even every 2 weeks if the patient is older and doesn't need to have a large mobility and movement. So how many products right now are available? You can see that we have 4 different longer acting products for hemophilia A and 3 for hemophilia B. The first 4 for hemophilia A are Elocta, Adenovate, GV, and Esperoct, with pegylation, glycopegylation, and FC fusion, and the half-life of these factors are increasing about 30%, and the number of injections is reduced by 3 times to twice. And in hemophilia B, as I said, there are Alprolix, Idelvion, Refixia for factor 9, which is FC fusion and glycopegylated and pegylated products with significant increased half-life, which is reducing significantly up to 50 to 60% the half-life of the factors. So how we have to measure the activity of this factor, and this is an important point, especially for those products that are pegylated and glycopegylated. You might need to change the strategy of the measurement of the actor and the assay. The normal APTT assay might not be enough, and you need to have the chromogenic assay, which is a little bit of problem for the small centers, because these assays are not easily available or expensive, and you need a well equipped lab to be able to use them. And that's something in the future hemophilia treatment center around the world to get use about it. What about patients with inhibitors and non-replacement therapy? As I mentioned before, we have about 1/3 of hemophilia, severe hemophilia A patients that are developing a neutralizing anti-factor VIII antibody in 1/3 of them, where their infusion of factor VIII is not anymore enough during the acute bleeding. And that's the reason the strategy that we do use is to measure the level of inhibitors, and if the level of inhibitors is less than 5 Bethesda unit, we can use a high amount of factor VIII, and if it's over 5 Bethesda unit, we do need in the acute bleeding to use the bypassing agent or activated complex of prothrombin. And for prophylaxis, in order to prevent the bleeding, we were used to use the APCC and recombinant factor 7A. And these are, of course, expensive, and the efficacy of the treatment was about, especially in prophylaxis, because in the acute bleeding, no doubt, and in the prophylaxis, the efficacy was reported about 60 to 70%. Eradication of inhibitor was used and still is used about the huge amount of factor VIII in the beginning of development of inhibitor in order to get rid of antibody, and that is very expensive with everyday infusion or 3 times a week with a high amount of factor, and there are different strategies which I'm not going to get through, but the cost of such a treatment could be about $400,000 up to €1,000,000 for patient. And as you can imagine, this strategy is not going to work for most countries around the world, and particularly those countries with the low resources. Now, where we are standing with other most modern type of treatment, we have bispecific antibody, which is a monoclonal antibody binding to factor IXA and factor X and trying to make the enhancement of thrombin generation without the need of factor VIII. And you can use this molecule in hemophilia A, hemophilia A with and without inhibitor. Of course, you cannot use it in hemophilia B because you need to have the factor IXA. There is a biosimilar which is called MIM8, which is in clinical trial and in the future would come, and there are other type of biosimilars that we don't have to go through now. So there are other type of strategy like siRNA targeting antithrombin, targeting monoclonal antibody, TFPI, and the SERPIN-PC. What they are doing, all these strategies are extremely important to rebalance the coagulation. So we are using the system of clotting to have procoagulant factors and anticoagulant. With the use of these 3 categories of drugs, we are using the inhibitors against the natural anticoagulant, and that is making an enhancement of thrombin generation and improving the prothrombotic situation in the patient with hemophilia, therefore reducing the bleeding in this patient. But let's start with the first non-replacement therapy. As I said, this is ACE910 chimeric bispecific humanized monoclonal antibody against factor IXA and factor X, mimics factor VIII, binds to these with 2 arms, as you can see here, with these 2 molecules of IXA and X, and that again make the placing spatially appropriate position and promoting the generation of thrombin. So 7,000, almost more than 7,200 hemophilic patients around the world with and without inhibitor have been used, because this drug has been approved for those patients with and without inhibitor in Europe, in US, and in lots of countries around the world. The results of the clinical trials in Haven 1 to Haven 6 is already available, and those results are reporting the efficacy of treatment and safety in adult and in children. And as you can see, with starting of 3 milligram weekly for 4 weeks, following with 1.5 milligram per kilo, we are able to reduce significantly the ABR with a significant improvement in terms of the bleeding and quality of life of patients. However, still we can see that we haven't seen 100% of the patient achieving 0 bleeding. And that's what's happening now in Europe to understand the efficacy of these drugs compared to the standard product. Because we know the efficacy of this drug for prophylaxis, we haven't seen any head-to-head randomized clinical trial. There is a trial significantly showing the efficacy and safety of the product compared to the historical data in the same patients. What about the side effect? We have seen few microangiopathic thrombotic events, which fortunately has been stopped by stop of the usage of prothrombin complex activated at the time of the acute bleeding for those patients that are treated with emicizumab. And again, we have to be careful when these patients are having the acute bleeding to understand that these are not any more severe patients, and we have to treat him like a mild patient and should be treated with a really lower amount of the factor 7A, and in order to prevent any kind of side effect. In terms of death, 44 patients have been died, and we have to understand now what is the safety and efficacy. Soon, I think it would be a paper coming out to show the fatality in the patient using emicizumab. Again, we know patients with hemophilia are dying. The most important thing is to understand whether the safety and efficacy of this drug is differing to what we have seen before and whether that is similar. About the anti-emicizumab, anti-drug antibody, only one neutralizing and one partial neutralizing antibody has been seen with loss of efficacy of these patients. Now, how we are going to measure the efficacy of this drug in our labs? You remember for the pegylated product we have said that chromogenic assays are necessary and we have to introduce it to our labs. For the emicizumab, things are a little bit more complicated. You cannot use the APTT because only small amount of the molecule is enough to shorten the APTT and giving you 100% similar factor VIII, which is not the reality. So this is not factor VIII and you cannot measure it. However, you have to know that you can use actually the bovine chromogenic assay for the measurement of factor VIII when your patient has the acute bleeding and you are treating the patient with factor VIII. But when the patient is a hemophilia A with inhibitors and is treated with a bypassing agent, and you want also to measure what is the level of anti-factor VIII antibody, you can use it by the chromogenic assay, human-based chromogenic assay. So this is complicated. That means you have to have in your lab both chromogenic assay, bovine one, as a source for the measurement of factor VIII, and the human one for the measurement actually of the inhibitors against. And if you want to see the factor VIII-like potency of the emicizumab, then you can use a APTT modified version, and even or otherwise you can use the chromogenic assay. So that means again there should be a real education and teaching to your team how a patient in treatment with emicizumab during acute bleeding, when the patient has antibody against factor VIII or doesn't, how should be treated and how the efficacy has to be evaluated. As a last part of my talk, I'm touching the gene therapy. So we have seen with the extended half-life product, we improve the trough up to 2 to 3%. With non-replacement therapy, we can achieve about 10 to 20% as a trough, but still there is a lot of discussion whether that amount is enough for the spontaneous bleeding. I would say there is no doubt, but what about the minimum bleeding or the traumatic bleeding? So in that case, you always have to add additional factors, and the goal of gene therapy is to replace the dysfunctional gene with the exogenous functional gene to cure the proper disease or to have a long expression of the factor. What is important to know in terms of the gene therapy in hemophilia? You have the cDNA of the factor that you want to infuse, factor VIII or factor IX, and you have the vector, which is bringing your cDNA to the organ, target organ, in this case is liver, with an appropriate promoter to have a significant amount of expression, which could be durable without a spontaneous or traumatic bleeding in your patient, and the patient should be able to stop the prophylaxis. And where we are, lots has been done. And as you can see here, there are several companies that are working in gene therapy of hemophilia A. The most advanced one is BioMarin, by almost normalization of the factor in the patients with one single infusion in peripheral vessel, just one injection. And now we are in phase 3 clinical trial, and more than 130 patients have been treated. However, the results of 2-year follow-up of this patient is available for a limited number of the patients. As you can see also, some of the company like Takeda stopped the treatment because of some of the non-satisfactory result, and the details are not yet available, but other type of company are ongoing. And let's go to see the results of BioMarin. Here there are 2 dosages of, you can see, for the injection of 2 groups of patients with lower amount and higher amount. And when we are using 6 per 10 to 13 VJ and on kg, we have a level of expression which achieve more than 170. And that's amazing how we would never imagine a few years ago that in a short time we would be able to normalize completely the level of expression of the factor. However, we have to also think about that after 52 weeks, means a year, the level of expression went down about 20 to 30%, and now the level of expression is about lower than what was before. And now it's very important to understand this amount of expression for how long time would be durable, and that is important in terms of selection of the patient and also the cost of gene therapy, because we have to understand what should be the cost of this gene therapy in the future. And also that's very important also in the developing world and also developed world, how we have to move on. All of us, we were convinced that at the end of next month, we would be able to have the approval of FDA for the BioMarin gene therapy. However, surprisingly, we have seen the reject of FDA, not in terms of proper rejection, but just asking further information for at least 2 years follow-up on 134 patients that have been enrolled in the clinical trial of BioMarin. So that's the reason that type of data would be available in 2022. And so that means a delay in the arrival of gene therapy for all centers around the world. So what about hemophilia B? Hemophilia B, we can see that is also very exciting, and BioMarin was, Unicure, sorry, was the company which achieved earlier than the others with the usage of AAV5, a good result of expression, followed by Spark, which now would be distributed with Pfizer, and the Freeline, Sangamo, Unicure, and Takeda, as I said, and SGI-MI, and Takeda stopped or discontinued the treatment. But let's see the results of Unicure, and as you can, the Spark activity factor 9, as you can see in 8 patients, good level of expression, almost more than, I would say, 40% for a long period of time. And what are the critical issues now in both in hemophilia A and hemophilia B gene therapy? There are a few aspects that we need to consider. The increase in liver enzymes, the safety profile of different adeno-associated serotype, and what is the effect of the vector manufacturing process, whether the same vector in the different company would have the same effect, and how we are going to evaluate that. The most important issue is the potential genotoxicity driving from integration of the adeno-associated, which we were not used to know, but now we know that a portion, even a small portion, but portion of the adeno-associated vector is getting integrated, and we do need to have more and more information information by biopsy, liver biopsy of the patient treated with gene therapy to understand how much that could be associated to any toxicity in the future. And as I explained before, we need to understand how we are going to measure the activity of factor VIII and factor IX and its discrepancy in the future, and how we are going to compare the different results of one clinical trial to the other one. So I would say most scientists in the different centers around the world are working on that aspect, and my invitation would be to keep an eye to the sites of ISTH educational I would say, committees who are working very hard for teaching every person around the world for understanding the basic on gene therapy and the clinical data on gene therapy, and getting also the trace of EHC and EHAD to understand how the organization of the center should be done. So I think there is no doubt now that the gene therapy would become the most and greatest biotech success in the 21st century. There is a promising modality for future medicine, which is personalized treatment, and more information, of course, is needed for this field of therapy, which is very innovative and lots need to be learned. And we had to add on what I said, education for patient, for physician. We need to understand about the safety and efficacy. We need to prepare our site, how they have to use gene therapy in the future and what they have to do, even for the novel drug. The accessibility is very important. We are not living in the same reality around the world, and that would get even worse with the COVID and with the economical problems around the world. And we need to understand how the accessibility would be better and better for all patients around the world, and the clinical delivery for all patients. And with the hope that all these drugs would help us to treat more and more patients, and not staying with 1 out of 5 patients having the accessibility to the drug. I want to thank you all for your attention, and happy to get any question from your side.
Dear Professor Peyvandi, many thanks for your awesome lecture, and thanks for joining us again. Here is one question, as you see in the chat section. I want to ask you just for this, that how can we find that the antibody is against factor VIII or Lenovo factor VIII?
Actually, it doesn't matter, because the reason why you are measuring the factor VIII antibody against factor VIII is how you have to organize yourself for the management of the patient with hemophilia and inhibitor during the treatment in prophylaxis with emicizumab. If your level of anti-factor VIII endogenous or by treatment is more than 5 Bethesda unit, you cannot treat the patient with factor VIII, and you do need to use the bypassing agent like factor VIIa or prothrombin complex. And if the level of inhibitor is less than 5 Bethesda unit, you are allowed to use factor VIII for the treatment on top of emicizumab therapy.
Thanks a lot again for answering and paying attention. And again, many thanks for joining us.
Thank you for the invitation, and good
You're
luck.
welcome. Have a nice day. Good luck.
Thank you. Bye-bye.
Goodbye.
Bye.
Okay, and we have 2 questions from dear Professor Abboud. If you are with us, dear Professor, I want to ask you these 2 questions.
Here I am.
Thanks a lot. So nice of you. Thanks a lot. If you're ready, if you are having my voice.
Go ahead.
Okay, thanks a lot. Is therapy need for alkalinization in pain control?
Mm-hmm. Yes, in the past, we used to think that we need to alkalinize these patients because acidosis leads to increased sickling. Now, I don't generally alkalinize if the patients are not acidotic, okay, then we really don't need to add any bicarb to the fluid. I just give D5 half normal saline. I don't like to give, I like to give hypotonic solutions to get the water inside the red cell. Now, many patients do develop some time of acidosis the older they are, and in those patients, if needed, I will try and correct the acidosis with some acetate or something, but in general, I just use regular hydration without alkalinization. With D5, half normal, hypotonic, say, half normal saline. And what's the other question?
Thanks a lot, dear professor. And the next question, what is the hydroxyurea mechanism in controlling symptom and what is the doses? What are the doses? Sorry.
Okay, that's a very, very good question. You know, hydroxyurea, as I said, has a multimodal mechanism. One, it increases fetal hemoglobin that can interfere with sickling. Two, it's a DNA synthesis inhibitor, so it will lead to larger red cells that have more water content in them. So less of these dry, irreversibly sickled red cells. Three, it decreases high white count. And high white count is a risk factor in sickle hemoglobin. Four, the reticulocytes have less adhesion molecules on their surface. And five, hydroxyurea is a nitric oxide donor. So multiple mechanisms. Initially, it was thought to be the increase in fetal hemoglobin, and that probably is the most important. But all of these other mechanisms play a role, lowering the white count, increasing the solubility of the hemoglobin and the hydration of the red cells. Now, there are a couple of ways to give hydroxyurea. One of them is to start with 20 milligrams per kilo. And some people, like the baby hug study, was a fixed dose, 20 milligram per kilo. Most people will start with that, and then they would increase by 5 milligram per kilo every 5 to 8 weeks until you see a decrease in white cells and platelets. And usually we try to maintain an ANC above 2000. And this is called, and the platelet count above 100. And this is called reaching the maximum tolerated dose. And it's a little bit higher in children. And my colleague, Dr. Ware, likes to take patients to the maximum tolerated dose. And he has shown that those patients have higher hemoglobin, higher MCV, higher fetal hemoglobin. And if I were to make a recommendation, I think that would be the best. I myself start patients at 20 milligram per kilo. And if they do well, I don't escalate the dose. If they are not responding, I escalate to 25 and then 30 over a long period of time. So there are two ways to do this, but the one that seems to be winning is to go to maximal tolerated dose, even though I don't use that a lot. And one of the reasons in Lebanon is that if you're going to go to MTD, you're going to have to monitor the patients a little closer. And these days, we don't have the ability to do that. But that is what, you know, is the best recommendation I have. Sorry, I cannot hear you.
I'm sorry. Thanks a lot for your informative and complete answer and definition.
Thank you.
Again, thanks a lot, dear professor. You were our biggest honor in the panel and in the Congress, and one of the dearest lecturers we have. Hope and wish to see you and host you in person one day.
Are you done with the questions for Dr. Peyvandi? If she is on, I had a question for her.
All the questions from your lecture and Dr. Peyvandi's lecture were finished. If you have a question, yes.
Okay, I can email her. It's all right. Thank you.
So nice. Thanks a lot. Thanks a lot. Again, many thanks. We are going to the next speaker, everyone. I hope you all had a good time and enjoying the panels. Next, we are going to have Dr. Khaled Ghanem with us from Pediatric Oncology Unit, BASMA, Damascus, Syria.
Yes, thank you
Dr.
very much.
Ghanem.
Thank you very much for the invitation, and I am honored to be with you today to present about challenges of acute lymphoblastic leukemia therapy
Again, thanks a lot. Thanks a lot for accepting our invitation, and nice to see you again. If you're ready, we can share. You can share your slide, and we can start your lecture.
Yes, for sure. Do you hear me?
Yes, clear voice.
Thank you very much. I am sharing my screen
now. Good luck.
Yeah. Okay. Okay, so now you see the screen?
Yes, dear professor, we are seeing your slide. Go ahead.
Yeah, thank you very much. So today, I have no conflict of interest to disclose. Today, I will talk about challenges of acute lymphoblastic leukemia therapy in developing countries, which consist of low and middle income countries. So acute lymphoblastic leukemia is the most common childhood cancer, and it is the most common hematologic malignancy. The most common presenting symptoms are pallor, fatigue, fever, ecchymosis, and bone pain. Diagnosis is made through bone marrow aspirate and biopsy. Usually the samples are sent for immunophenotyping nowadays through flow cytometry to decide what is the type of leukemia, if it is ALL or AML, or if it is B cell or T cell. And usually in some centers, they do extensive genetic studies. In low and middle income countries, they do sometimes basic genetic studies to identify the risk of the disease. Treatment consists of multi-drug chemotherapy regimens for 2 to 3 years, usually according to the protocol used. Allogeneic hematopoietic stem cell transplantation is reserved only for very high-risk patients or for refractory cases. And in recent days, the protocols, the indications for transplant are getting less and less with new molecular and targeted therapies. So the major issue in developing countries is that this is the most common childhood cancer. This is the most common hematologic malignancy in childhood. And the treatment outcome, the overall survival in low-income countries is little or is very decreased in developing countries compared to developed countries. In some European countries and in the United States, the outcomes for low-risk disease is more than 90%. However, most low-income countries, the outcome is little, it is less than 50%, and in some countries, the outcome is less than 20%. So why this discrepancy is present in the outcome of acute lymphoblastic leukemia? And according to assessment, this difference is due to challenges in both diagnostics and treatment. And I will detail these challenges with proposed solutions in the next few slides. So first, the first diagnostic challenge is timely diagnosis. Delayed diagnosis in acute lymphoblastic leukemia impacts treatment outcome, especially in high-risk ALL. So when the patient presents with a very high white count, if the case is Philadelphia positive ALL or it is T-cell ALL with a very large mediastinal mass, the outcome will be impacted significantly because of first respiratory and vascular compromise, second because of high risk of tumor lysis syndrome, either due to the disease or due to the therapy itself. So what are the causes of delayed diagnosis? First, in low-income countries, there is delayed healthcare seeking. So the patient has more than one symptom of acute lymphoblastic leukemia, but the parents, they don't get the kid to the doctor for appropriate physical exam, history, and initial investigation. So this is the first cause of delayed diagnosis. It is delayed healthcare seeking. And the second cause, in some rural areas in low-income countries, even if the parents get the kid to the doctor, there is a delayed referral from the primary healthcare provider. It is either a pediatrician or a general care provider doctor. Then the doctor does not refer the patient to the pediatric oncologist or to a referral center for appropriate investigations. And the third challenge is delayed initiation of treatment even after diagnosis. So if the referral care center is in the capital of the country and there are a high load of patients, sometimes the patient is diagnosed, but the therapy is not initiated appropriately even after diagnosis. So what are the proposed solutions for this, for these challenges? First is to increase public awareness. So the pediatric oncologist in low-income countries and in developing countries, they have the duty to increase public awareness about the common signs and symptoms of childhood leukemia. They should go to community to talk to people and to increase the awareness about that. In Syria, we had last year, before the COVID pandemic, we have held one public awareness campaign. It was supported by WHO. We went as doctors and we had this panel, we had our other consultant, my colleague, Dr. Al-Yusuf, our head nurse, and one of the patients who survived cancer. We went and we had this public awareness to increase the awareness of the public community about early signs of childhood cancer, especially leukemia. Now, what is the solution for delayed referral to tertiary care center? Here, the solution is to increase awareness of primary healthcare providers to refer the patients early. We had planned for a similar awareness campaign to primary healthcare providers like pediatricians, but because of the COVID-19 pandemic, we have delayed this plan. And what is the solution for delayed initiation of treatment after diagnosis? It is by establishment of a structured referral network after the confirmed diagnosis of acute lymphoblastic leukemia. So what about appropriate risk stratification? This slide shows the balance between the treatment intensity and toxicity. So if we increase the treatment intensity for childhood acute lymphoblastic leukemia, the disease eradication will be more. However, the toxicity will be higher in these cases. So the best outcome is when this line is horizontal. So we have a balance between disease eradication and between therapy-related toxicity. Modern treatment protocols stratify patients to, depending on the protocol, but generally to low risk, average risk, and high risk. Usually low risk patients, they require the least intensive chemotherapy. Average risk, they require an intermediate regimen, and high risk, they require the most intensive chemotherapy plus or minus stem cell transplantation. So how do we base risk stratification for these patients? We base them on clinical factors and genetic and early response factors. So why in developing countries, this risk stratification is not being done well? Regarding clinical risk factors, usually if we cannot, countries with difficulties in even basic things like basic childhood cancer care elements, the patients are not being treated on protocol-based therapy. So here, the clinical risk stratification is not being done. Now, in a little bit more developed countries, in the developing world, usually there are clinical risk stratification factors, but advanced genetic and early response factors are missing due to technical barriers for that. So this is a major challenge in this study. This is an old study. It was very well known. These are ALL patients when the patient is enrolled in a study and a protocol-based study, the outcome is significantly higher than those patients who are not enrolled in protocol and on clinical trial. And we all know that clinical trials for acute lymphoblastic leukemia and protocol-based therapy is being used less in low and middle income countries compared to high income countries. So what about accurate response assessment, which is the third diagnostic challenge? So accurate response assessment is essential, and current therapy protocols rely on early response to remission induction chemotherapy, which is the first phase of therapy. And early response is measured by what is called minimal residual disease, or MRD. MRD is a specific bone marrow test to measure the percentage of active malignant blasts by either immunophenotyping. So in most protocols, we start chemotherapy on day 1, for example, and then either on day 15 or on day 35 of therapy, we do another bone marrow exam, and we send the marrow for flow cytometry exam. Here, the flow cytometry examination for residual disease is different from the phenotyping or for the flow cytometry exam of the newly diagnosed patients. So in most protocols, this is based on flow cytometry, and on a few protocols, it is based on molecular exam. So what is the main barrier for this accurate response assessment in developing countries? The main barrier is technical here. So we are facing this challenge in Syria. We send the bone marrow at the end of induction. It is read as the first bone marrow. So there is no accurate MRD technique. So we cannot know if the patient is responding well or not responding well. And we cannot stratify the patient on the appropriate protocol based on MRD. And in most modern countries, the patients are stratified, and MRD is a major part of risk stratification. Now, what about treatment challenges? The first treatment challenge is protocol adherence and abandonment. Abandonment is defined as the failure to start or complete indicated curative therapy. So in low and middle income countries, there is a high rate of abandonment of therapy compared to developed countries. And this is due to main reasons. The first one is financial difficulties. So there is a high cost of therapy and high cost outside therapy cost for these families, like food supplementation, like transportation, like housing cost if the patient lives far away from the hospital. So these are major factors that affect the high or will lead to high abandonment rate in developing countries. Belief that ALL is not curative or is not curable, there is in some low socioeconomic communities in low-income countries that cancer is not curative. They don't believe that there is a high chance of cure for ALL, so that they don't bring the patient for therapy, or they don't, even if they bring the patient to the tertiary care center after the doctor explained the protocol plan, then they don't believe in the doctor's thoughts, and they refuse to put the patient on the treatment plan. So usually in many developing countries, due to collaborative plans between high and low income countries, the abandonment rate is getting less in recent years. What about treatment-related toxicity? I am back to this slide, which shows that if we increase the treatment intensity, we will be controlling the disease more, but the toxicity will be higher, and the best outcome is achieved if this line is horizontal. Treatment-related mortality in developed countries is about 1 to 2%. However, this study from Dr. Gupta from Central America showed that treatment-related mortality in multiple countries is Central America is up to 9 and 10 or 10%, which is higher than 10 times higher than the toxicity or treatment-related mortality in low-income countries. What is the major challenge behind this? The major challenge is there is no adequate supportive care. So the supportive care includes adequate hydration, adequate intensive care, adequate blood supply, platelets and blood, and adequate antibiotic therapy. So if the patient receives induction chemotherapy, he travels for 100 kilometers, he has fever at home, there is no hospital nearby, then there is high risk for death from sepsis in this situation. What is the solutions here? There is a huge effort now to do protocols adaptation. So you cannot use a protocol designed in the United States or in Europe in a country where there is very limited resources. So here the patients will die not from the disease, but from the treatment itself. So the protocol needs to be modified to have a good balance between treatment toxicity and disease eradication to reach the best possible outcome. What about cost of care? The cost of care is divided into cost of medical treatment and cost to families. So usually effect of cost to families is significant in low socioeconomic settings. So even sometimes food cost is high due to the low income, travel cost is high, housing cost is high compared to the income of the family, especially in these difficult days. The COVID-19 pandemic is here. There is a huge interruption of public transportation. There is there are multiple challenges in this part of the cost. High cost in induction and consolidation therapy usually. So the first part of the therapy is called induction, remission induction. The second part is consolidation. Here, the patient needs to visit the hospital frequently, like once or twice weekly for chemotherapy. They need to stay in the hospital if the patient develops fever neutropenia. So in this part of protocol, the cost is higher than in maintenance therapy. So maintenance therapy here in our protocol, the patient's appointment is once monthly, so the cost will be less. So the highest rate for highest cost is in the first two phases of therapy. What are the barriers? The barriers are financial resources in low and middle income countries, which is obvious. However, what is the solution? The solution for this is being held by partnership between NGOs and governments. So non-governmental organizations in many low-income countries, they have a major impact on decreasing the cost to families and cost of medical care. What are future perspectives to solve all these issues that will lead to decreased outcome of childhood acute lymphoblastic leukemia in low-income countries? So first, there is regional and international collaboration. There are multiple examples for this regional and international collaboration to try to solve these barriers. One of them is the SIOP organization. Second is the Pediatric Oncology Eastern Mediterranean Group, which is supported by the St. Jude Children Research Hospital in the United States. And the latest was the St. Jude Global Alliance. We are part of this alliance. The second thing to invest on is local public-private partnership. So here in Syria, BASMA is a non-governmental organization. We have our own pediatric oncology unit. It is operated by BASMA. However, it is operated by a special agreement between BASMA and the government. So the government provides our floor. We provide almost 70% of medication. We provide food supply, provide transportation and housing supply. So through this partnership, we are trying to reach the maximum possible outcome for these patients. So today I had this slide added on my presentation. Our short follow-up results here in our unit, we have 80 cases over the past 30 months. We are using a protocol, a European protocol for low and intermediate risk patients. It is an EORTC protocol. And we are using Sanjo Total 15 for high-risk patients. Why do we do this? Because according to our assessment, the EORTC is much easier for the families, and especially in maintenance therapy, where they get oral methotrexate and 6-MP. However, the EORTC high-risk protocol is very intensive. It has multiple blocks of high-dose RSE and a very intensive protocol. And here, our assessment was we will have a high risk for death due to this intensive protocol. The Sanjo Total 15 high risk, the families will suffer from frequent visits to the hospital. However, there is less intensive chemotherapy in consolidation and in maintenance. The total number of relapses in our patients over 30 months is 6. Treatment-related mortality is 3.7%. Disease-related mortality is due to relapse, and disease progression is 4 out of 80 patients, which is 5%. And the total number of survived patients now is 73 out of 80. We are doing the more detailed statistical analysis. I did not draw the Kaplan-Meier curves this morning. Many thanks for your invitation.
Thanks a lot, dear Dr. Ghanem, for your nice presentation. We really enjoy it, and it was really informative. Just for all audiences, I want to recall something that you told us. BASMA means smiling. I hope smile, happiness, and health for all patients in your departments. Nice to have you again.
Thank you very much for your nice wishes. Thank you.
Thanks a lot again to Dr. Ghanem. We are going to have Dr. Jorn Gerritsma from University of Amsterdam, Netherlands, Emma Children's Hospital, with red blood cell alloimmunization in sickle cell disease. Dear Dr. Gerritsma, can you hear me if you have my voice?
Yes, thank you. I can hear you.
Thanks a lot. Nice to see you. Nice to have you.
Thanks a lot for your invitation.
You're welcome, and thanks a lot. I want to give a big thanks to you to accept our invitation and give us the pleasure having you with us.
Thank you.
Take your time. If you want, you can share your slides and start your presentation.
Yes, thank you. I'm still not able to share my slides.
Okay, I'm gonna make you the co-host now. I'm so sorry for the inconvenience.
No, don't mind.
Okay, done.
Yes, thank you.
You're welcome. If anything that I could help you, let me know. If not, take your time.
Thanks a lot. Are you seeing my slides? I don't think so.
You start the sharing, but I have not your slide now.
Wait a minute, I'll do it again.
Maybe it's better to slide.
So I think you see the slides right now.
Unfortunately not. It said that, oh yes, now your slides is on.
Wait, I'll do it another way. Sorry.
No problem.
So do it this way then. Do you see the presentation right now?
Not now, no. Oh, yes, it's done, I think. It's going to be done. Yes, it's done.
Yeah, I don't. There's something weird happening here.
Can I help you?
Well, it's just flicking on and off the slides, so I cannot see my slides.
Maybe it's better to reshare, but share your screen, please. instead of sharing the file or something. It's better to try resharing.
Yeah, I'll stop sharing.
Nice.
And I'll again share my screen.
Spare, wait a minute. What happened there? Professor Gerritsma, if you have my voice, I lost your voice too. Your microphone is off. If you want, you can
Yes, do you hear me again?
Yes, yes.
Yeah, I don't know what happened.
If the problem is remaining, you can mail us the slides. Oh, it's correct. It's better. It's fine. You can start the slideshow.
Yes.
You have 20 minutes ahead.
Yeah, I'll just go on. Okay, thank you.
Go ahead.
Yes, I've nothing to disclose, so I can start my talk. Okay, I'll start with a boy who was admitted in our hospital. The boy had sickle cell disease and with a genotype SS. And in his medical history, he had an acute chest syndrome. And he had received repeated transfusion for sickle cell related complications. And due to these transfusions, he had developed an antibody to K and FVIII. And now he visited our hospital with at the emergency room with severe pain in his chest and a shortness of breath, and he was in need of oxygen because he had a low saturation. So, well, we already talked about the sickle cell disease, so you all know what it is. So I'll skip this part for now. So I'm going to talk about the transfusions. So we know, as Dr. Abboud already told, there are different indications for transfusion in sickle cell disease. We divide them in episodic transfusions and chronic transfusions. The episodic transfusions are mainly administered in the acute situation. For instance, if a patient experiences acute chest syndrome or symptomatic anemia, or as a preventive measure, if there's an upcoming surgery to prevent any sickle cell disease related complications in the future. Or we can give chronic transfusions, in which we give repeated transfusions every few weeks. And we do that as a preventive measure if a patient experiences repeated acute chest syndromes or recurrent vaso-occlusive crisis, or as a primary or secondary prevention of stroke. However, most times the transfusions all go well and the patient tolerates the donor blood. However, sometimes the patients do react to the donor blood and develop antibodies. Red blood cell alloimmunization is quite a complex disorder, and a lot of cells are involved, and we still are not able to describe the complete pathophysiology, but there are a lot of different immune cells involved. But what we do know about the risk factors for alloimmunization in sickle cell disease, well, one of the risk factors is the number of red blood cell transfusions. Another, the antigen mismatch between the donor and the recipient, infection and inflammation, and the possibly genetic polymorphisms. And I will talk to you about all those 4 points in more detail. So if you look at the number of transfusions, we have conducted a study here in the Netherlands in which we tried to find out what the cumulative incidence of alloimmunization in sickle cell disease was in our country. And what we saw was that 30% of the patients had developed an antibody after their 40th unit. So that's what you see in the figure. So that's a really high incidence of all patients that will form an antibody after one or more transfusions. And we saw that after those 40 transfusions, there were not a lot of antibodies formed in patients that received more than 40 units. And interestingly, so the biggest risk to form antibodies is still in your first part of the transfusion scheme, as we saw that 50% of all antibodies that were formed in our cohort were already formed after the 8th unit. So that's quite early on in their transfusion life, because they will receive, most patients will receive a lot of transfusions. And well, I say the number of transfusions is a big risk factor. However, we see still that there is a large gap between the general population, so patients, non-sickle cell disease patients that are transfused for all kinds of reasons, and sickle cell disease patients, because the general population only experience around 7% of alloimmunization after 14 units. So what are the other risk factors that make sickle cell disease patients prone for these antibodies? Well, I think one really important one is the antigen mismatch. In countries in Europe and America, at least, there is a different ethnic background of the donors and the recipients, with the recipients being mostly from African and Afro-American descent, and the donors from Caucasian descent. So they have a different makeup in their antigen profile, which makes it hard to match for all the antigens we give to those patients. Moreover, the sickle cell disease patients have a highly polymorphic Rh system, which has been described by Chu et al. In 2013, which you see in the right figure, are all different kinds of variants that are found in sickle cell disease patients. So not only the conventional RHD genotype or the conventional CE genotype, but a lot of variants. And the problem is that you cannot find all those variants if you phenotype the patient. So you mistakenly phenotype your patient as RHD positive, as a conventional RHD, and transfuse the patient with RHD positive blood. However, the patient having a partial phenotype can then possibly react to your rhesus D donor blood and making them prone for alloimmunization. Well, infection and inflammation. What we have seen is that infection is a trigger for alloimmunization to occur. If you look in the general population, this is a study from the Netherlands in which 490 patients, or around 500 patients that formed antibodies were screened and for their infection. And we have seen that if you have a prolonged infection from longer than 7 days, that there is a high risk to form antibodies compared to patients that did not have this infection at all. This is also what we have seen in mice, that if you add inflammatory agents to mice, that they react with antibodies, and if you transfuse them in the absence of inflammation, they do not form those antibodies. In sickle cell disease, we know there's a high rate of inflammation ongoing due to their acute chest syndromes, their VOC, so they're in a continuous state of inflammation. And this is also what we have seen in a study, that patients experiencing any inflammatory event for which they needed a transfusion are at a particular high risk to form red blood cell antibodies. So this remains a problem, as we have to transfuse some patients during an inflammatory event. Then there could be genetic polymorphisms involved that leaves the patient at risk for alloimmunization, as 70% of the patients, around 70%, will never form an antibody, how many transfusions they receive in their life. So there seems to be a responder or non-responder phenotype. So we performed a systematic review of the literature to find which polymorphisms are associated with red blood cell alloimmunization. And we have found 20 case control studies describing this issue, and we could perform a meta-analysis for alloimmunization to Duffy and Kell. And for the Duffy, we saw that there were 3 different HLA-DRB1 genotypes that were associated with antibody formation, either with an increased risk for HLA-DRB104 and HLA-DRB115, or a decreased risk for alloimmunization for HLA-DRB103. And if you look at anti-K formation, we saw the same pattern, but for different HLA-DRB1 genotypes. So there's for HLA-DRB110, HLA-DRB111, and HLA-DRB113 were associated with an increased risk of immunization to the K antigen. So this shows that there is a different risk profile for each antigen to alloimmunize against, possibly based on your HLA genotype. So for future, for the future, we might screen our patients for their HLA genotype to know what their risks are for immunization to certain antigens. Well, if we go back to our patient, he was diagnosed with an acute chest syndrome and needed treatment. It was a quite severe acute chest syndrome, so we gave them an erythrophoresis with 5 units, which were matched, of course, for K and WA because he had antibodies against those antigens. So initially he had a rapid recovery, his pain dropped and he had no longer an O2 demand. However, after 7 days, the pain came back and he developed dark urine, and he was diagnosed with a delayed hemolytic transfusion reaction, which is a severe complication of sickle cell disease alloimmunization. So what happens is that you transfuse red blood cells. However, if the patient has antibodies, they might engage your red blood cell and activate complements and induce complement-mediated hemolysis. And those reactions, well, their symptoms typically start between 3 and 25 days, and they include dark urine, an onset or a worsening of the anemia symptoms, and these anemia symptoms are typically lower than your pre-transfusion values, which is always striking. They often present with vaso-occlusive-like pain and an increased LDH. And there's quite a high incidence rate of this complication in sickle cell disease, with an incidence rate of 40.6 per thousand to 41.7 per thousand transfusion episodes. And I have to mention that these are the episodic transfusion episodes, and we do rarely see DHDRs in chronically transfused patients. So it mostly happens in patients who have received their transfusions during an inflammatory event. And the diagnosis of this complication is quite hard, as it mimics the symptoms of a vaso-occlusive crisis. So if a patient is administered to the hospital with these kind of symptoms, you have to know if the patient has been transfused during the last month. If so, you should also perform a direct antiglobulin test to see if there is an antibody reaction. However, if this test is negative, you cannot eliminate your DHDR, because some of our DHDRs are antibody negative, and we actually do not know yet what happens in those patients, but we see that there is a large complement activation, and it could be that it's a different pathophysiological mechanism, but we do not know yet. But to diagnose this complication, the best way to do that is to measure the decline in the percentage of HbA. So that's HbA is always of the transfused donor. So if you measure your baseline HbA after transfusion and you measure the percentage of HbA during follow-up when the patient is administered with symptoms, you can calculate via this tool what the DHDR likelihood is. And if the patient scores low, then there's no DHDR, you just can monitor your patients. Or if it's the patient scores an intermediate or high risk, you can confirm your DHDR and you should treat the patient accordingly. So what is the proposed transfusion, the proposed method? Well, the most important thing to do is to stop giving this patient new transfusions, because those new transfusions only can accelerate your hemolysis and does not help the patient. So if not necessary and the patient is not in life-threatening danger, you should not transfuse the patients even if they are anemic. What you should do is administer IVIG if there is a normal kidney function. Give a high dose of EPO if there is a reticulocytopenia, give preventive anticoagulation and standard supportive care. And if the patient is administered with a severe DHDR, there is a novel treatment which involves C5 blockage. So it's a complement cascade blockage, which you can give in the early stages of the disease and which has been shown to be effective. after even 2 infusions of anti-C5. And you can see that initially the total HB dropped very steeply and then rose again already after the first infusion. However, it's still very expensive at this moment, although there are currently, currently we only have eculizumab, but there are new eculizumab-like products that are going to be available, so hopefully the price will go down as well. But most importantly, we should prevent alloimmunization in all patients if possible. So what can we now do to prevent alloimmunization? Well, what we have studied also in the Netherlands in our study is what happens if you introduce extended matching. So the upper line, we show only patients that were matched for only HB0 and RHD. And the dashed line in the middle shows patients that were matched for RHC, E, and Cal additionally. And you can see that the incidence of alloimmunization drops. Well, the ASH guidelines in 2020 have performed a systematic review on this topic, and they showed that in the studies that were included that only tested HB0 and RHD, a cumulative incidence of 35% was seen, while if you match additionally for CE and K, the incidence drops to 18%. And if you even go further and also match for Duffy, KIT, and S, the incidence seems to drop to 8%. This is what we currently do in all patients in the Netherlands, but it is not what the guideline suggests, but this is mainly because the donor supply does not always suit this demand if you also match for Duffy, KIT, and S. So you should at least match for RH, CE, and Cal if your donor supplies allow that to. And it might be preferable to genotype all your patients because, as I have showed you, there are a lot of antigenic variants that could then be identified. However, we still do not know the cost effectiveness of this procedure. So if it's possible, you can do it. However, it's not clear if it's also cost effective in the future. So how do we increase our transfusion safety? Well, as I told you, perform an extended antigen typing of your patients, preferably, if possible, by genotyping to identify all the variants. And I think one really important one is to have a good documentation of alloimmunization history of these patients, particularly if they are treated in multiple hospitals. So you should know if in those hospitals the patient is transfused and has formed an antibody, as we know that in sickle cell disease, a lot of the antibodies fall below the detection limit over time, so you cannot find them after a period of time anymore. So a good documentation is key here. Then your compatible unit selection should be a minimal HB0, RHD, C, E, and K. And if the patient has formed at least one antibody, you should additionally match for Duffy, KIT, and S as well. And your screening for DHDR should optimally include an assessment of your HbA percentage during follow-up for diagnosing the diagnosis of this complication. So to conclude, red blood cell alloimmunization remains a serious complication of red blood cell transfusions in sickle cell disease, and especially the sickle cell disease patients are at a particularly high risk to form those antibodies. We now know that extended matching might reduce those alloimmunization risk, although it still remains high and remains a problem, and we should definitely look further into this issue. I want to thank my colleagues from the Amsterdam Università and St. Queen, the blood bank in the Netherlands. And thank you for this opportunity to talk.
Dear Dr. Gerritsma, thanks a lot for your nice and informative presentation. It was a big honor to have you and also joining this awesome lecture.
Thank you. Thanks a lot for the opportunity.
You're welcome. Thanks a lot. Wish you a good day, a good evening.
Yes, thank you.
Take care. Okay, thanks a lot to Dr. Gerritsma with the awesome presentation. On the next spot, we are going to have Dr. Izaskun Elorza Alvarez, with a conventional schedule in pediatric acute lymphoblastic leukemia from University Hospital Vall d'Hebron, Barcelona, Spain. Professor Izaskun Elorza Alvarez, can you hear me? Dear Dr. Elorza Alvarez.
So we can access the presentation in the website.
I think we don't have Dr. Elorza Alvarez with us. Okay, in this point, in this middle, maybe she's going to be on. I want to again remind that all the presentations, all the panels, and all the lectures are going to be accessible from the website, Congress website, and the Congress application. You can download all the presentation and all the lectures. And also, again, if you have any question, you can ask in the chat section. For getting the information about next panels and other days program, you can visit the website and other social media pages. Again, I want to announce Dr. Izaskun Elorza Alvarez, if you're online. I'm sorry that I think unfortunately we won't have Professor Elorza Alvarez. Okay. Again, many thanks to Professor Miguel Abboud, Professor Flora Peyvandi, Dr. Khaled Ghanem, and Dr. Jorn Gerritsma for awesome and nice presentations. We had very good panel and very good hours together with you. And I wish health and happiness for you all. And it's our biggest honor to have you together. And also it is our biggest wish to host you and have you all here in Iran in person and have a face-to-face meeting with all of you. I'm honorful to be a small part of this meeting today.